Hi, I'm Dr. Sarah Raven.
And I'm Dr. Tara Martos.
And we are here to present a circle of safety, preventing and coping with relapse. A few introductions just to start out. I am a licensed psychologist in private practice in Coral Gables. I've been in private practice here for about 10 years, and I specialize in working with children, adolescents, and young adults with various types of eating disorders as well as anxiety and depression. I work primarily from an FBT and CBT treatment model. And I'm also a professional advisor for F.E.A.S.T. And I'd like to introduce my esteemed colleague, Dr. Tara Martos.
Hi, my name is Dr. Tara Martos, and I have been working with Dr. Raven for about 5 years now. And I'm her postdoctoral fellow, and I've also been in private practice here in Coral Gables, which is near Miami, for the last 3 years. And like Dr. Raven, I also specialize in providing FBT services for children, adolescents, and adults. And I also come from a CBT model when treating anxiety and depression.
Let's begin.
So what is a relapse? Well, a couple things that we should know about a relapse before we begin. The definition of a relapse is that it's defined as a deterioration in health following a period of improvement. And for the purposes of this presentation, what we're going to define relapse as is a return of the eating disorder and the eating disorder symptoms for a sustained period of time following a period of remission. And a relapse must be differentiated from a slip or a lapse. It's actually really important because, you know, when you think about something, let's say like BN, bulimia nervosa, we might have a client who maybe has one purging incident. That doesn't mean that it's a full-blown relapse. It has to kind of be over a longer period of time. Those behaviors have to be more sustained. So a slip or a lapse may involve one or two occurrences of eating disorder behaviors or one eating disorder symptom. In the absence of any other symptoms or of changes in weight loss, and things like that. A relapse involves a pattern of change in thoughts, behaviors, emotion, and or health over a period of time or several weeks. We usually will see changes in weight and so other behaviors that are a little bit more concerning over a longer span of time. An eating disorder relapse may involve the emergence of new symptoms that were not present during the initial period of illness. So a really good example of this might be a client who had initially presented with anorexia nervosa, and they've gone through the refeeding stages, and they're at a healthy weight and they're doing well, and all of a sudden they start to develop symptoms that look a little bit more maybe like a binge eating disorder or something like bulimia nervosa. So those are some things that we have to kind of be on the lookout for as well, just the emergence of some new symptoms.
How common is a relapse? Well, unfortunately, relapse is fairly common. As you can see from these statistics, this is what we know from research studies. For anorexia nervosa, we know that the risk of relapse is somewhere between 35 and 41%. For bulimia nervosa, it's around 46%. For F.E.A.S.T, which is other specified feeding or eating disorder, basically a category of people who have eating disorders but don't fit neatly into any of the other diagnostic criteria, the relapse rate is around 41%. And for binge eating disorder, the rate of relapse is somewhere between 20 and 50%, depending on the study that you read. So as you can see from these percentages, somewhere between a third and a half of people who recover from eating disorders will eventually relapse. So it is not uncommon. When do people relapse? Well, to be honest and to be frank, the risk of relapse is always present. However, the risk of relapse is greatest during the first 18 months after initial recovery, and this has been borne out in research studies. There are a couple of reasons why the risk of relapse is so high in those first 18 months. One of the reasons is that brain healing takes a long time. Brain healing takes at least a year, often up to 2 years, after weight restoration or after cessation of behaviors such as binging and purging for the brain to fully heal. So once someone may look normal on the outside or may no longer be engaging in any eating disorder behaviors or may not even have any eating disorder thoughts, that doesn't mean that the brain is fully healed. The person is still very vulnerable. In addition, when someone is 18 months or less out of full recovery, they haven't had enough time really to solidify recovery-oriented behaviors. So their neural pathways may not be fully rewired in a recovery-oriented way yet. That takes time and many months of practice, many months of consistent full health and consistent recovery-oriented behaviors in order to attain.
So why do people relapse? I think it's really important to remember that eating disorders are a chronic illness. And this is so important because if you think of somebody, let's say, who has diabetes or somebody who has asthma, which are common chronic illnesses, you might have people who go for a long period of time with their symptoms kind of under the radar, their symptoms are under control, everything is being managed really well, and then all of a sudden they have an asthma attack, a couple years down the line. So eating disorders are very similar to that. It's always something that you're going to be living with, but you could definitely have it maintained and under control for a very long period of time. Another thing to remember about what a chronic illness is that it's an illness that lasts for longer than 3 months, and there's not a vaccine that's going to prevent it. It's not going to be cured. Again, like diabetes or asthma, it's something that you're going to be living with for the rest of your life. And so you always have to be careful with it. There are certain factors that predispose people to developing an eating disorder, and those are unchangeable. So there is a genetic component here. There are certain temperaments and kind of personality characteristics that we see that go together, that fit the mold of someone that would have an eating disorder. There's also certain situations that can trigger an eating disorder that are pretty common. And some of those are avoidable, like starting a diet, which is usually a pretty common trigger that we see, or participation in certain events that encourage thinness, sometimes different athletics or joining a certain gym. Those are all things that could trigger an eating disorder. But there's other things that are unavoidable. So medical issues, life stressors, accidental weight loss, even accidental weight gain, different life transitions. Those are some things that can trigger eating disorders. And we also live in a culture that really idealizes fitness, normalizes and encourages kind of diet and eating disorder behaviors. I mean, just look at social media, look at any Instagram, just the constant selling of diet products or a certain bikini or try this weight loss system. So unfortunately, kind of the environment that we live in this and the society that's around us and the goals and ideals of that society are unlikely to change anytime soon. And so that's another reason why some people would relapse. Some predictors of relapse. So 19 years or older at the time of discharge from treatment, a longer duration of illness, receiving inpatient or residential treatment, stressful life events, greater body image disturbance at the end of treatment, lower BMI at the discharge of treatment, binge purge subtype of anorexia, or premature treatment, discharge from treatment, So one of the things that you might be looking at here is like receiving inpatient or residential treatment. That seems pretty intensive, so you would assume that that person might be safer from having a relapse. But the truth is that you have to look at these factors as correlational, not causal. So remember, correlation does not equal causation. So if someone is in inpatient or residential treatment, what that really tells you is that the severity of their symptoms was pretty intense, that it required inpatient or residential treatment. And so they're much more likely to relapse than, let's say, someone whose symptoms could be managed through outpatient kind of weekly sessions. There are also some protective factors against relapse. So being younger than the age of 18 at the time of discharge or treatment. So if we kind of catch the symptoms earlier on and we treat them earlier on, you have a much better chance of not having a relapse. Also achieving full weight restoration before discharge from treatment. A strong social support system. This is so important, and especially since Dr. Raven and I are family-based treatment providers, we know the importance of having a really strong network that buys into treatment and is able to help and support you once you are returned home and in remission, if you were in residential treatment, receiving exclusively outpatient treatment, and receiving family-based treatment.
All right, so how does a relapse occur? I'm going to talk a little bit here about the cognitive behavioral model of relapse, and this is something that is borrowed from the substance abuse literature. A lot of what we know and the way that we talk about relapse in eating disorders is borrowed from what we know about addiction. Addiction research, addiction recovery, and that sort of thing. So again, this cognitive behavioral model of relapse is borrowed from the addiction literature. Eating disorders don't spiral out of control overnight. So a person isn't fully healthy and recovered or in remission one day and then very ill the next day. That's not how it happens. It takes many days, usually weeks or even months, for someone to go from a state of health to a state of an eating disorder relapse. So it generally starts out with some sort of high-risk situation. For an eating disorder, a high-risk situation may be something that's fairly benign to a non-eating disordered person or a person who's never had a history of an eating disorder. Especially for anorexia nervosa and other restrictive eating disorders, any energy imbalance, meaning any situation in which a person is not taking in as much energy as they are expending, that creates a high-risk situation. And that energy imbalance could be either intentional through dieting or healthy eating, or it could be unintentional through stress, through a period of depression, through wisdom teeth extraction, through getting an abdominal illness that causes a lot of vomiting, any type of situation in which a person's nutritional needs are not met, even for a brief period of time, even if it's just for a couple of days, for someone who is vulnerable, that can be enough to initiate the cycle of relapse. So when someone is in a high-risk situation like that, there are basically two different ways that it can go. A person can cope with that situation effectively by reaching out for social support, by using some of the tools that they learned in treatment. An effective coping response, in my opinion, and in the work that we do, would also involve an appropriate response from parents, family, clinicians, caregivers, from people that are very close to that individual, in terms of closer monitoring of symptoms, increasing the frequency of treatment sessions, that sort of thing. But often people will not be able to cope effectively with that type of situation, especially if there is not a lot of social support, or especially if a person, for reasons of shame, guilt, or just lack of awareness, doesn't disclose to anyone what's going on. So if a person is not coping effectively with that situation, for example, with a slight weight loss, they may start to experience some, you might say, positive effects of that situation. So if a person, let's say, has been recovered from an eating disorder for a couple of years, they lose a few pounds after getting their wisdom teeth taken out, and they discover, hey, I feel a little bit better, I look a little bit better. Then that, unfortunately, that positive judgment of what's happening can increase the likelihood of spiraling into a relapse. So with this lapse right here, in the substance abuse community, it might be like one episode of using drugs or one episode of drinking alcohol. With an eating disorder, it might be one episode of binge eating, one episode of purging, one instance of skipping a snack or skipping a meal. Then we have the abstinence violation effect, which is basically like, well, I already screwed it up, so I might as well keep screwing it up. And with something like binge purge symptoms, sometimes that might be, well, I've already purged twice, I might as well keep on doing it. I've already messed it up. With a restrictive eating disorder, it might be something like, well, I skipped my snack yesterday and today, and I'm fine, nothing bad happened. So I'm just going to continue to skip snacks. And although maybe doing that once or twice may not be harmful, doing it repeatedly is very likely to trigger a relapse. So that's a model of how relapse often occurs. So then how do we prevent relapse? Well, with eating disorder treatment, I typically recommend that we spend several sessions, maybe 3 or 4 sessions towards the end of treatment, discussing how relapse occurs, discussing perhaps how the eating disorder developed for this particular individual, discussing any triggers that they have in their life or triggers that they anticipate having in the future, discussing what types of situations might be high risk and how to either avoid those situations or manage them mindfully with care and with social support. I think it's really important to balance acknowledgement that the risk of relapse is real. I think it's important to be very candid about that and balance that with the knowledge that people can empower themselves. You know, recovering patients can empower themselves. Parents can empower themselves with tools and knowledge and skills and plans to mitigate that risk of relapse. So we're trying to hold two truths simultaneously here. The last few sessions of treatment, we will often work with a patient and their parents and any other clinicians and any other loved ones collaboratively to create a written relapse prevention plan that they can then carry with them into the future post-treatment to help them stay in remission.
So what does relapse prevention planning look like? Well, the first thing that, to say is kind of what the topic of our whole presentation is today, is relapse prevention plans really create a circle of safety around our patient. And how we do this by a couple different strategies. So the first thing that we do is we facilitate open communication between the patient, family members, any other loved ones, as well as any clinicians that might be involved in the case. And this is so important because I think a lot of times, especially when people are in remission, they don't want to talk about the possibility of relapse. And so getting that out in the open and saying, okay, this is a really real threat. This really is something that we have to plan for. I think it makes it a little bit easier for someone to say, hey, I noticed something that was a little bit concerning and let me bring that up. They're going to feel a lot more comfortable in session to bring it up with you, to bring it up with the identified patient. And so we want to make sure that any loved ones, anyone who has buy-in into this case is involved. We also want to make sure that we help them identify early signs. And that's really important to kind of provide that education to people because there's some kind of overwhelmingly glaring signs like maybe losing weight or restricting food intake, but there might be some smaller covert signs. And so being able to educate caregivers and loved ones on some of these signs as well is extremely important, and also providing clear guidelines about what needs to be done and how it needs to be done so that other caregivers or other clinicians can go ahead and intervene in the process, and how we can get the ball rolling on helping someone if we start to see that they're kind of starting to slide into a relapse. So one of the things that we also have to talk about is when would we start talking about this? Because again, it's like, it might seem a little bit uncomfortable to bring this up when someone is thriving and is doing well in treatment and has been in remission for a long time. But it is something, again, that it needs to be discussed, and especially needs to be discussed, obviously, before we discharge from treatment. So that has to be really important. We can't just say to the person, okay, bye, you're okay, we'll talk about this later and go on your merry way. No, before we discharge clients or before we even maybe step them down to maybe a lower level of care in terms of less frequent treatment or things like that, we want to be able to have this plan in place. And the plan should be revised periodically, usually every 6 to 12 months. Because remember, life circumstances change, especially when we're working with adolescents. They might be going off to college, or they might be graduating from college and relocating for work. And so those are things that we also need to plan for. And so we have to kind of have frequent revisions to make sure that any new life circumstances are taken into consideration when we're talking about relapse planning. And who should be a part of this? Again, any loved ones, any caregivers, anybody who has really had active participation with the client, active participation in treatment, they all need to be involved. So that can be boyfriends, that can be, best friends, that can be a spouse, those are, parents, grandparents, things like that. There's a couple things to note here that I think it's so important to bring up is that, again, when we're talking about kind of that revision in life circumstances, there might be a romantic partner now that's here, or a best friend. And so bringing those people in too, because remember, let's say if someone gets married and they move out and they're living with a partner now, then the partner needs to be involved in that relapse planning. That's so important. Another thing, sometimes we don't have parents involved in treatment. And sometimes it's even counterproductive to treatment to have a parent involved. So again, making sure that you can bring in anybody who is close to that person, who, again, it could be a romantic partner, it could be a best friend. I've even had situations with a client that I'm working with currently where, the best friend, the boyfriend, and the boyfriend's parents are the people that are providing her with services and are currently helping her now that she's in remission from the eating disorder. So, if there's any new healthcare providers that are involved, so sometimes, over time, different medical issues arise and they might be working with a cardiologist now or a rheumatologist now or some other doctor. And so making sure that those doctors also are aware of the eating disorder and, that person is in remission. Oh, no. Oh, sorry, something happened to my screen. That any new treatment providers are also involved in the relapse prevention plan so that they can look and they can see if they go to a primary care physician that maybe there's a weight loss, and that's something that should be brought up or, taken a look at as opposed to just saying they're dieting and weight loss is fine. Because we do see that, unfortunately, sometimes in healthcare. So really anybody, who is kind of involved is going to be involved with this person's treatment needs to be made aware of the relapse, relapse prevention and of the person's medical history as well. And how does relapse prevent, how does it look? Well, one thing to keep in mind, Dr. Raven and I are both married to lawyers. And so what we know about being married to lawyers is that everything has to be in writing. If it's not in writing, then it didn't happen. And that's the same thing for relapse prevention planning. It has to be in writing. It has to be very clear cut. And every person involved, any doctors that they're working with, again, any other clinicians that they might be working with, any family members, romantic partners, caregivers, anybody, again, that's kind of invested in this person's treatment needs to have a copy of the relapse prevention plan in writing. And this isn't something that just happens in one session. It's really talked about and revised and discussed over a kind of a series of sessions so that everybody is really clear about what the expectations are, about what the, certain symptoms are, the signs of relapse. Everybody's really clear about what they're looking for and what's going to happen if they see it and what they're going to do if they see it. So again, everyone has copies of that.
Okay, so why do we engage in relapse prevention planning? Well, in short, because it works. Relapses, unfortunately, are common. And in my experience, going through the process of relapse prevention planning and having everything in writing and having a thorough discussion about it is extremely helpful. In my experience, most relapses happen when people drop out of treatment prematurely before they get to the relapse prevention planning phase. So I've actually seen that happen a number of times when someone gets to a point where they're doing very well, but they're not fully, they haven't fully completed treatment. They haven't done relapse prevention planning. They stop coming to treatment. And then a year or two later, I get a phone call that the person is in crisis again. And that's really, really sad and really unfortunate because I believe in many cases, relapses are preventable. Certainly not all cases, but in many cases, relapses are preventable. And if a relapse is not preventable, then it's still possible for the patient and his or her loved ones and clinicians to intervene early in the course of the relapse. For example, after symptoms have been happening for a few weeks, to prevent that relapse from becoming a longer-term relapse or a more severe relapse that may require a higher level of care or more disruption to the person's life. Another important reason why relapse prevention planning has to happen and why it has to be in writing is anosognosia. Those of you who aren't familiar with this term, anosognosia is a neurologically based inability to recognize that one is sick, to recognize that one needs help, And this is primarily characteristic of anorexia nervosa and restrictive eating disorders. It also can occur sometimes in bulimia nervosa or binge eating disorder. But because of the anosognosia, it's oftentimes not possible for a patient to recognize that he or she is slipping. If it were, then this whole process would be a lot easier. So towards the end of treatment, a lot of patients will say to me, well, Dr. Raven, why do we have to do this? Why can't I just call you if I'm having symptoms again? And my response is, you can and you should, and I hope you do, but that's probably not enough, because of the way that this illness takes hold of brain functioning. It alters self-perception, it alters judgment, it alters insight, particularly in the areas of food, weight, exercise, self-perception, exactly the areas that are affected by the eating disorder. So this is why it's so important to have a plan in place that involves a circle of safety around the patient. It kind of allows us to bypass the anosognosia. Another issue is that oftentimes when people who've recovered from an eating disorder start to experience symptoms again, they have a lot of shame and guilt and embarrassment around the fact that they're struggling. And they may think, well, I should be better than this, or I should be over this, or, my parents worked so hard to spend so much money getting me well. How can I possibly be struggling again? There may be a lot of self-blame involved. The patient might feel fearful or anxious about telling their parents, or about telling me, or about telling anyone how they're feeling, because they don't want to go through the hell that they've already went through in the past. They don't want to go through a grueling recovery process again, which is understandable, So this may prevent people from reaching out for help when they need it the most. And that's why that circle of safety is so crucial. In my experience, relapse prevention plans can be empowering. They can be empowering for the patient. They can be empowering for the family, because they help everyone to kind of recognize and understand that relapse is a real risk. It could happen. And there are concrete steps that we can take to help mitigate these risks and to help our son or daughter stay well. And I think that can be very empowering for the entire family.
So, like I mentioned a little while ago, everything has to be put in writing. So what exactly are we putting in writing? So we're going to talk a little bit about just some of the elements of writing a relapse prevention plan. So the first thing that really needs to come up in conversation are some of the signs. Some of the ways that we would identify that something is happening. And again, that our client, or our patient might be slipping into a relapse. So there's some objective signs and there's some subjective signs. And those are things that we need to discuss. So, the client has to be open with us about what are some of the internal kind of signals of struggle that they're having, negative thoughts, maybe some more secretive behaviors, and they have to be open, kind of honest with us, and that has to be included in the relapse prevention plan. But then there's also the more observable, more objective signs that, an outsider would be able to see, something like weight loss or restricting a food intake. And both of those objective, subjective, external, internal signals need to be included in the relapse prevention plan. So we like to kind of look at it like a 3-step model, like a stoplight. And so the first signal that we're going to look at are the green light signs. And that's basically the indicator that the eating disorder is still in remission. So that means that the person is still in a healthy target weight range. They're eating consistently. They're eating independently. They're able to eat a wide variety of foods without really any distress or anxiety. They're not participating in any binging or purging behaviors. They're able to eat regularly with friends. They're maintaining a pretty, stable mood. So those are some of the green light signs that, again, would let us know that, our patient is doing well and that the eating disorder remains in remission. Then there's some yellow light signs that we need to look for, and that might suggest that there's maybe some early struggle, some early signs that the eating disorder is returning, and we're going to have to kind of be on alert. Again, it's kind of like slow down, like a yellow light. You were going to slow down here. And that's what's going to happen, again, kind of in this phase in relapse prevention planning. So some yellow light signs might look like, like there's been some changes in weight. Maybe the person has fallen a few pounds below their target weight range, for example, and we're starting to maybe notice some downward trends in weight for a couple periods of time. Anybody could have a slight fluctuation of pounds. And, you might see that in one session where someone falls below, and then the next week they come back and they're back on target again. So we really want to see that it's kind of consistently happening, over the course of a couple weeks, that there's kind of a downward trend. Perhaps they've missed a menstrual cycle. Perhaps they've had maybe one or two instances of binging or purging. Maybe we're seeing some mood swings. Or they're getting a little bit anxious or defensive when they're talking about, eating or weight or anything like that. We also might see some restrictive, like maybe something, kind of small. So like, I'm going to cut out bread, or I'm maybe not going to eat this snack. And they're doing that a little bit more consistently than just a 1 or 2 time thing. And then a red light sign is a pretty good indicator that a relapse has occurred. And so that would be that the weight has fallen about 5 pounds below the target weight range. And we've seen that, pretty consistently over a period of time. That there's been multiple, 3 or more episodes of binging or purging, that extreme anxiety around food or food restriction or eating or gaining weight has returned, and that there's been at least 2 missed menstrual cycles.
All right. So after creating the assessment tool with the green light, yellow light, and red light signs, then we move on to the second part of writing the relapse prevention plan, which are the interventions. So the interventions also correspond to a traffic light model. The green light interventions are... Intervention might be a misnomer here, because basically a green light intervention is a form of basic self-care or basic self-monitoring that is intended to keep the eating disorder in remission and to keep the person in an optimal state of health. So for example, someone who achieves remission from anorexia nervosa during high school and then is going away to college, we may have weigh-ins scheduled periodically every week, every 2 weeks, etc., at their student health center to make sure that they're maintaining weight. We may have an agreement that the person has meals with friends X number of times per week. And this would be for a college student, for example, to make sure that eating remains fun, that it remains social, and to make sure that the person has adequate support around meal times. For some people who are in remission, they may continue to meet with a therapist on an occasional basis or on an as-needed basis. That could be a monthly session, that could be twice a year type session, that could be an as-needed thing. But the purpose of that is that, there's still someone there, still a professional looking out for you, someone that you can check in with and talk to just brush up on coping skills and make sure that things are okay, and talk about things and come up with some strategies to make some changes if you start to struggle. In terms of green light interventions, some other things that can be very helpful here are hobbies and passions that keep people well. So some people, for example, really enjoy playing a musical instrument or playing a particular sport or painting or drawing or attending yoga classes or going to church. Just things that help people feel well mentally, spiritually, and physically. All of these things would go under green light interventions. The yellow light interventions come up when a person is showing yellow light signs, when a person has shown some signs of struggle that they need extra support. So essentially the whole point, I think the meat of the relapse prevention plan lies here in the yellow light interventions, because the whole purpose is for the patient or his or her loved ones to catch it when it's been a slip or a lapse before it becomes a relapse. So when a person is showing yellow light signs, some yellow light interventions that could be applied at that time might include more frequent weigh-ins. So for example, maybe a person's been weight stable for a very long time, but if their weight starts to drop a little bit, we might resume weekly weigh-ins for a period of time until their weight has stabilized again. For someone who is still living at home and has been in remission for a long period of time, we might we might have a requirement of more frequent meals with parents, just so that they have that extra support and monitoring around meal times to make sure that they're getting their needs met. We may recommend adding additional nutritional supplements. So for example, a lot of people during a weight restoration phase will have an Ensure or a Boost or a daily shake or smoothie. Sometimes it may be necessary to add those back in during yellow light times when there's a struggle. If a person is a young adult living independently, it may be useful for that person to come home for a long weekend, to come home for a week or two, for a brief period of time, just to, to get back on track before resuming their usual life. And then the red light interventions are interventions that we put in place when we've identified that someone is relapsing. So when there are red light signs, these are the things that we do as soon as possible to stop the relapse immediately. I guess something rather encouraging or optimistic is that once people have been through recovery from an eating disorder and have gone through relapse prevention planning, the majority of the time, if there is a relapse, the patient or parents are able to catch it much sooner than they were the first time around, because of what they've learned, what they've been through, the skills that they've developed through the process of recovery the first time. So, a person, for example, who presents initially for treatment with bulimia nervosa may have been binging and purging for a year or two before they start treatment. But a relapse might involve, let's say, 2 weeks of binging and purging. So as I'm sure you can imagine, it's quite a bit easier to bounce back or recover from a 2-week relapse versus a year or two of one's life, really immersed in an eating disorder. So some examples of red light interventions might be for a college student, an immediate medical leave of absence to return home and focus on recovery for the rest of the semester or for the rest of the school year, depending on the person's needs. For someone who is an athlete, it may involve taking the rest of the season off from that varsity sport so that they can focus on recovery and then returning to the sport if it is safe in the future when they're fully recovered. A return to all parent-supported or loved one-supported meals and snacks for a period of time may be another example of a red light intervention for someone who has relapsed. Okay, so this Venn diagram, I think is a really good illustration of a helpful or adaptive attitude to maintain about relapse prevention planning. So this Venn diagram is borrowed from radically open DBT or RODBT, which is it's a modification of traditional dialectical behavior therapy, and it's a fairly recent evidence-based treatment that's been used to treat people with disorders of over-control, such as chronic anorexia nervosa, chronic depression, obsessive compulsive personality disorder, chronic anxiety, and autism spectrum disorder. So this Venn diagram represents basically 3 different over-controlled states of mind. The 2 that you see in the circles there, fixed mind and fatalistic mind, are 2 unhelpful ways to view relapse. And the flexible mind, the one that you see on the bottom, is, I think, the most helpful or adaptive way to view it. So when someone is in a fixed state of mind, change is unnecessary because they already have the answer. So, for example, I've heard this so many times. When a person, this is typically an adolescent, is at the end of their treatment and we start to talk about relapse prevention planning, they get really upset, really mad, and lash out and say, like, I'm not going to relapse. And they're very angry that we would even consider the possibility that they might relapse because they are so certain that they're going to stay well forever. And, this is a tricky thing to manage, because when someone says that, I usually believe that they're genuine. Like, their intention, the heart behind it is genuine. The person has worked really, really hard to get where they are in recovery. They genuinely believe that they're going to stay well, that they're not going to relapse. And I admire that optimism. I admire that positive thinking. However, it can lead to problems, because if there's no openness to the possibility that relapse could happen, then planning doesn't occur. And the reality is, about 30 to 50% of people do relapse. So it does happen. So I think it's wise to entertain the possibility that it could happen and plan for it. Kind of like having flood insurance or fire insurance or hurricane insurance here in Miami. So the other issue about fixed mind, when someone says like, I'm not going to relapse, and gets very angry and adamant about that, is, to gently remind them that a large part of the eating disorder is beyond their control. Their intention may be very strong and very genuine that they will not relapse, and I believe them. And, the person has a biologically based brain disorder that they are in remission from at this time, but that things may happen that are beyond their control and sometimes even beyond their awareness that might influence them to relapse. The opposite of fixed mind is what's called fatalistic mind. And when a person is in fatalistic mind, change is unnecessary because there is no answer or there is no solution. So an example of fatalistic mind would be like, well, why did I even go through this recovery if I'm just going to relapse? Or like, why do we even bother doing all this if I'm just going to have this for the rest of my life? Like that type of attitude, it's very, very negative, that assumes that things are going to be really bad, or assumes that there's no point in trying to make things better or in trying to mitigate risk. So with someone like that, I think it's really important to point out that many relapses can be prevented, and that, the person's already been successful in treatment and getting to this point where they're in remission. And if you even just look at it statistically, at least half of people, perhaps more, don't relapse. So statistically, the odds are in your favor. So then when it comes to the flexible mind, this is the ideal, the most mindful and adaptive and helpful way to view relapse prevention planning. So when someone is in a flexible state of mind, they're open to the possibilities, they're open to the facts, and they're open to feedback. And they are willing to be honest with themselves and others, and to collaborate in working towards helpful solutions. So when someone is in a flexible mind, whether it be the patient or their parents or their boyfriend or girlfriend or husband, working collaboratively with this open and flexible attitude can be really, really adaptive in terms of writing a really effective relapse prevention plan and sticking to it.
So kind of an example of the flexible mind that I think is kind of in, pop culture, and something that is, pretty, we've heard it multiple times probably throughout our careers or throughout our lives, is a serenity prayer. God, grant me the serenity to accept the things I cannot change, courage to change the things I can, and the wisdom to know the difference. And why we talk about that here is kind of in conjunction with Dr. Raven's, what she just discussed about the flexible mind. It's so important to have kind of open and frank conversations with your clients, with their families, about the factors that influence relapse that we don't have control over, and the things that we have to accept because we can't change them, like the genetics, again, a person's characteristics or temperament, their genetically determined body type, the history of their eating disorder, the way at which their body functions optimally, any other comorbid disorders, whether there's other psychological disorders or even other medical disorders that might be playing a role in their weight. Even, past trauma events from the past that could be playing a role in this. And also, we had mentioned a couple slides ago, the culture in which we live in, and kind of this culture that really embraces and rewards thinness. And, unfortunately, as much as we would love to try to make some changes in some of those areas, especially in the cultural aspect that really rewards and embraces thinness, we unfortunately can't make some of those changes. And so being able to accept that and to work with it, but also to recognize the things that we can change. And the things that we can do to prevent a relapse. So that's making sure that we are able to maintain a healthy weight for life. And a healthy weight for life means a weight that is healthy for us, not just physically, but also mentally and spiritually and emotionally, that we find that really happy weight where we feel really good and, again, mentally and physically. That we're monitoring weight regularly to make sure that we're not losing weight, that we're seeking out therapy if it's necessary. We're avoiding diets, we're avoiding and kind of embracing that culture that rewards thinness, that we're seeking out medical care if we need it. We're not engaging in food restriction. If the patient needs psychiatric medication, that they're able to get that medication. They're open to nutritional counseling. They're also maintaining open communication with clinicians, with their family members, if they are developing, any symptoms of relapse. And they're practicing good self-care, and they're reducing stress. So again, recognizing all the things that maybe they can't change and accepting that, but then also recognizing all of the things that they can change and making sure that they're frequently working towards, always achieving those goals.
All right, some tips for parents on preventing relapse. Number one, I definitely recommend beginning relapse prevention planning after the eating disorder is in remission, but before being discharged from treatment. A little caveat on that, I'm very aware that many people are discharged from treatment prematurely through no fault of their own, either because their insurance company is no longer going to pay for it, or because they live in a country such as the UK with nationalized healthcare and people only get a limited number of sessions. There are any number of reasons why a person may no longer be in treatment when it's time for relapse prevention planning, and that is okay. A relapse prevention plan can be done and can be written and can be followed without any clinicians. Clinicians really are not necessary as part of a relapse prevention plan. If you have them and they're good, great, awesome, use them. But if you don't have them, you can go without. All you really need are more than one responsible adult, the patient plus one or more, ideally 2, 3, 4, 5 responsible adults who can create that circle of safety around the patient. So if your child is no longer in treatment and you haven't gone through relapse prevention planning, that's okay. Don't worry, don't fret. You can go ahead and do it on your own with all of these recommendations without any clinicians. Work collaboratively. Make sure that every person, including the patient, including any clinicians if there are any involved, and any loved ones have a say in it. And that everyone's in agreement with the plan that is created. Put the plan in writing and make sure everyone has a copy. That is very, very, very important to make sure that there are no misunderstandings or no he said, she says that come up later. Maintain close communication with your child and with your clinicians and with anyone else who is a link in that circle of safety. That communication is absolutely vital. In my experience, when I've been working with patients who achieve full remission and then have a relapse prevention plan and go away to live independently, when relapse does happen, it's almost always because of one or both of two things. Number one, there's a lack of follow through with some of the measures that we have in place. For example, a student in college who skips a few weigh-ins at the health center, and then suddenly they are 10, 15 pounds below their ideal body weight. That's an example of lack of follow-through, or a lack of communication. So if there's a person in that circle of safety who is concerned about a patient, who has observed symptoms, or who has some type of worry about the patient's well-being and doesn't communicate that worry to the other members of the circle of safety, then intervention can't happen, or at least not in the most effective way. So in my experience, those are the two ways that relapse often happens when there is a plan in place. And so for that reason, I very strongly recommend close adherence to the plan that's in place, and close and open communication between all people in that circle of safety and between those in the circle of safety and the patient, him or herself. If at all possible, I recommend keeping your child at home with you until he or she has been medically healthy, fully weight restored, and abstinent from eating disorder behaviors such as binging and purging for at least 6 to 12 months. And the reason for that is because relapse is most likely in that first 6 to 12, even 18 months after initial recovery. And also because a person has a chance to practice recovery-oriented behaviors in the home while they still have the safety net of their parents and close friends, loved ones around them before moving on to live independently. And that just really helps to solidify recovery and make relapse less likely. It's generally not that difficult for people to maintain remission once they've already recovered and have a firm relapse prevention plan in place. But it is very difficult for people to achieve recovery independently, while living by themselves. And so for that reason, I almost always recommend recovery happening at home with the loved ones, unless there's some very, very convincing reason why that's not in the best interest of the patient. I recommend that parents help their child build resilience and recovery skills while living at home by providing opportunities for independent eating and symptom management and trial and error, such as restoring lost weight independently before the child or young adult begins living independently. And the reason for this is because, again, we're trying to acquire a skill set and acquire resilience. So if parents are 100% or even 75% or 50% in control of the child's food and maintaining very close supervision until the day before he or she leaves for college, that's not in the patient's best interest, because that doesn't give him or her a chance to, to practice, okay, oh my goodness, my weight dropped a little bit this week. How can I bring it back up? How can I get it back on track to move forward? And that's a very, very, very vital recovery skill, because inevitably in life, there are going to be situations where food intake is substandard for any number of reasons, some uncontrollable, or when weight drops for any number of reasons. And it's so important for a person living independently to have already developed the skill of being able to restore weight on his or her own. And then finally, I recommend having your child or young adult child meet with a clinician of some type periodically for at least a year or two after the eating disorder has been in remission as part of a relapse prevention plan. And this is really only relevant if you have access to a quality clinician that you trust. It could be a psychologist, it could be a therapist, a dietitian, even a psychiatrist or a primary care physician, anyone that is very familiar with the patient's history that they can check in with and who can be an added support to them. And so I think that first 1 to 2 years after full remission is when it's really essential for that. I wouldn't say essential, because recovery can happen and remission can be sustained without it, but it can be very helpful to have that clinical support for a year or two after remission.
So what are some top tips for parents that are coping with a relapse? I think the first thing is admitting that there's a problem. And that's usually the hardest thing for most people to admit. So it's really accepting that the relapse has occurred and then committing to taking effective action. And again, I know that can be really hard for parents because we're wired to keep our kids alive, and everything in our bodies wants to help our children. And so there's a sense that sometimes it's really hard to accept that maybe they're sick or that there's a problem, because we almost don't want to see that. And so, but we know that if we do want to keep them alive, we do want to effectively keep them healthy, then we do have to, again, accept that there's something wrong and commit to taking effective action. And so we have this wonderful quote from Viktor Frankl: when we are no longer able to change a situation, we are challenged to change ourselves. And so again, that's really important to recognize as a parent, okay, when have I gotten to a point where I maybe need some outside help, or we maybe need to take a little bit more intensive action in order to get this eating disorder back under control again. Some other tips that we have is really just maintaining an attitude of compassion and non-judgment towards yourself and your child. That's so important because, sometimes, unfortunately, we start to think, is there something that we did wrong as a parent? Or, you might say, oh, well, you started dieting, and so this is kind of your fault. So we want to, no judgment and compassion, recognizing that this is not a choice that your child would choose for themselves, and making sure that they're also aware that you're there with them every step of the way, that, even if this is a situation where your child was treated as an adolescent, and now they're an adult, and, we don't say, oh, you're 18 now, bye, you're going to do this on your own, know that you're still there, that you're still going to be able to support them for as long as they need it, that you act swiftly, because again, what we know is, like how Dr. Raven said a couple slides back, the yellow light interventions are really, the meat of this. If we can identify those really early on symptoms and signals that something is happening and that this eating disorder is kind of brewing again, we can go ahead and take active and swift steps to stop it, quickly, and kind of stop it dead in its tracks. And so we might want to start arranging for treatment again, or bringing back supported meals and kind of some other changes that we'd be able to do, early on before there's a full-blown relapse. remembering what worked the first time is so important, and doing what worked. So again, if supported meals worked really well the first time, you want to bring those back in. But also recognizing that maybe your child is at a different stage in their life, and so maybe those needs look a little bit different. So for example, if your child is now an adult, maybe you're not going to their work and eating with them. That might look a little different, but maybe you're meeting outside of work, right? So just recognizing that things might look a little bit different, but kind of, the basic structures of what worked before are still going to apply. Also taking, if you have a child who's a young adult or is an adult and they're maybe in college or they're working, maybe considering bringing them back home. I think what this kind of quarantine and self-isolation has taught us that people can really work from anywhere now. And so, maybe remote learning is an option, or even working from home while, and your child can be in the home and be kind of immersed in those recovery-oriented behaviors and have that support and supervision from you during mealtimes, but they can still effectively maybe attend classes and work. And so, but definitely, not just leaving somebody where they are and saying like, no, you can try to handle this on your own. The research has really shown us that having that familiar support is so important during relapse time.
A few more tips for parents on coping with relapse. When a relapse occurs, this is a really good time to create a relapse prevention plan if you haven't already done so in the past. Ideally, you've already created one, but if you haven't, this is as good a time as any to create one and take into account the lessons that you guys have learned from this relapse. If a relapse prevention plan has already been written, maybe it was written a year or 2 or 3 or 4 ago when circumstances were different. And now it's time to revise. And again, it's time to take into account some of the lessons learned from this relapse and perhaps bring in some different supports, because perhaps the person has other support people in their life now that they didn't have at the time when the relapse prevention plan was first created. I also think it's really, really important to look for the silver linings that can come with a relapse. And I say this because I've worked with many patients who've been through relapse and have emerged from it much, much stronger in recovery than they were before the relapse. Sometimes that happens because when a patient initially goes through treatment when they're very young, let's say 10, 11, 12, 13, they go through a course of family-based treatment, they recover, then they go through a relapse, maybe at 16 or 17, or maybe in college. They may not really remember much of what happened during their initial recovery. And it's quite possible that during their initial recovery, their parents did the lion's share of the work. But this time around, when a person's a bit older, when a person's in late adolescence, early adulthood, they're a lot more cognitively aware of what's going on, and they have a lot more to live for, really, if you will. They have a lot more personal goals and personal motivations, and a life that they're planning, or a life that they're already engaged in that's incompatible with the eating disorder. So a relapse can very often be a time for a person to really internalize full responsibility for staying well and preventing relapse in a way that might not have been possible during their initial recovery because they were so sick or so young. When people go through relapses or any type of life challenges, that's an opportunity to build resilience and strength and to really learn from those experiences. People who never have struggles or challenges, I don't think there are any people who don't have struggles or challenges, but those they don't really have the opportunity to develop strength or to really look inside themselves or reach out to others and find out how strong that they are. Oftentimes, a relapse can be an opportunity for a person to slow down and reflect on, what was working in their life, what wasn't working. Do they want to change course in life? I've actually seen this happening a lot to a lot of different people during this coronavirus situation, when we're all kind of, slowing down. We're a lot more limited and restricted in what we can do. It's an opportunity for people to look at their life and think like, gee, I really enjoy that activity. I miss it. And I didn't like that activity at all. I don't want to do that anymore. So sometimes when people relapse, they may decide, hey, I hate soccer. I've always hated soccer. I don't want to play soccer anymore. I want to be an actor. Or something, they might choose a completely different activity that's really more in line with what they truly want, not something that they were doing on autopilot, or to get into a good college, or because all their friends were doing it, or some reason like that. Oftentimes when people relapse, they may choose to transfer to a different college, to change their major, to break up with a significant other and start dating someone else, to go with a whole new group of friends. There may be a number of life changes that might be catalyzed by the relapse and by just sort of the person's opportunity to reflect, look at their life, and rebuild it in a way that's a lot more congruent with their values and more authentic to who they really are. And then finally, spending more time with loved ones. This is probably something that we're all getting a little tired of by now at this point, coronavirus pandemic. But before all this happened, if you might remember, people didn't spend quite as much time with their loved ones as they are these days. So, the opportunity to take a leave of absence from college, or to, take a break from varsity sports, or to leave that apartment that you were living in and come stay with your parents for a few months. Those are opportunities to build closer bonds with the people that you really love and care about, that probably wouldn't have happened if it weren't for a relapse or a global pandemic.
So the following quote from a great American poet really summarizes a positive attitude towards relapse. I'm not afraid to take a stand. Everybody come take my hand. We'll walk together through the storm, whatever weather, cold or warm. Just letting you know that you're not alone. Holla if you feel like you've been down the same road. And this quote really resonates with Dr. Raven and I, because it talks a lot about a lot of the, attitudes and that we need to have when we're trying to take a stand towards relapse. Taking a stand, for example, right in that first line. Solidarity between the patient and their family members, being there to support each other unconditionally, seeking support from other people who have been in a similar experience. There was kind of a lot of elements of this quote that really stood out to us when we were thinking about relapse.
So for those of you who aren't familiar, this is a quote from Eminem's song, I'm Not Afraid, which is from his 7th studio album, Recovery. And that's a sequel to his 6th studio album, Relapse. And that's it. It was lovely to be a part of this event. We're really honored and flattered that we could be here and contribute to this Feast of Knowledge event. And I'm sorry that we weren't able to be in Sydney, but apparently Australia will still be there after the pandemic, and we would both really, really love to go at some point. What I hope you can see from this picture is that Dr. Martos and I are not just colleagues, we're also very, very good friends. We're very, very similar in many ways. We want you to know, if you would like to reach out to us, if you have any questions about the presentation, just holla. You can contact us by email. Both of our email addresses are here.
Thank you so much. It was an honor to present to you all.
Goodbye.
Bye.